Hello, everybody. My name is Virginia Kaklamani from San Antonio Breast Cancer Symposium, and I have with me Dr. Sara Tolaney, who's the Chief of Breast Medical Oncology at Dana-Farber Cancer Institute, and this is another version of SABCS Snippets. So, Sarah, we had two press releases just yesterday, the first one coming from the Ascento-04 trial. Do you want to just describe the trial for us and what you think all of that press release means for the future of breast cancer treatment?
Yeah, no, thanks for having me, Virginia. So it was a crazy day to see two press releases on the same day with practice-changing data. So that's incredible for the field and incredible for our patients. So Ascento-04 is a trial that is a phase III registration trial that randomized patients with metastatic triple-negative breast cancer whose tumors were PD-L1 positive on central testing, and they were randomized to get sacituzumab govitecan with pembrolizumab or treatment of physician's choice chemotherapy with pembrolizumab, with the idea being that we've had data from KEYNOTE-D19 that really established chemo-pembro as the first-line standard of care for those patients with PD-L1 positive tumors. But we also have known that ADCs like sacituzumab govitecan are very efficacious, in fact, better than chemotherapy in pretreated triple-negative disease. And there's a lot of robust data suggesting that ADCs can be synergistic with checkpoint inhibition. So the idea was, could combining sacituzumab with pembrolizumab do better than chemo-pembro? And we saw in the press release that, in fact, the combination of sacituzumab and pembrolizumab led to an improvement in progression-free survival that was noted to be both clinically meaningful and statistically significant. So hopefully we will see those data at an upcoming meeting soon.
So, I mean, honestly, I expected the data to be positive, and I was waiting for this because I've been wanting to do this in practice for the past several years since the initial ASCENT data came out, showing that sacituzumab improves benefit compared to standard of care chemo. So now, of course, this is not going to be the only study in that space, right? We're going to have the Tropion studies looking at Dato-DXd. So if you have this, beautiful magic ball and you're looking in the, 5 years from now, how do you think that we're going to be using these agents? And what is your preferred agent to use in that first line setting? Again, assuming all of these studies are positive.
Good question. I wish I had a very good crystal ball. So I think what we know is that I think ADCs are better than chemo for our triple negative patients. So I assume that we will soon also see data for the PD-L1 negative patients. So those patients we consider IO ineligible. There's Ascento-03, which will compare sacituzumab to chemo head to head. If I had to bet, I would guess potentially sacituzumab would win, just given what we know in pretreated disease. And then there's Tropion-Breast02, very similar kind of population, randomizing patients to Dato-DXd or chemo in that first line PD-L1 negative setting. And so hopefully we'll see, but hopefully those trials will be positive, and then we'd have choice of picking sacituzumab or Dato for that upfront therapy. And then for the PD-L1 positive setting, we've seen again the press release for Ascento-04. There's also Tropion-Breast05, which has a little bit more of a complex design because it's looking at Dato-DXd with or without durvalumab, and then comparing that to, in essence, a KEYNOTE-355 chemo-pembro regimen. So, assuming in the future we also have Dato-Durva as an option, then you may have choice of Dato-Durva or SG-pembro in that upfront setting. So I think, we'll have to see the data from all these trials to really be able to figure out how to choose regimens. I also think it's going to be kind of complicated 5 years from now with thinking about our crystal ball, because the early space setting is also changing, right? We're studying using these agents, for the post-pre-op setting with either SG, which is being looked at in Ascento-05, or with Dato-DXd and Tropion-Breast03. So patients may get exposure to ADC in the future in the early stage setting. And so then if they recur, obviously that presents a different question. What would you give that patient? So again, as everything evolves, all these questions are going to start to evolve. I think the other questions are going to re-expose someone to immunotherapy who may have had immunotherapy in the early stage setting. We're going to have to figure that question out as well. So I think a lot of unknowns with all that will change. But I think for now, it's really exciting to shift that ADC, in essence, from the second line setting where we've traditionally been using sacituzumab, to be an opportunity for patients, at least for the PD-L1 positive patients, hopefully very soon, in combination with Pembro, because, again, it is great to see that we can do better than what we've been achieving with chemo Pembro alone.
And assuming the data is like the press release says, clinically meaningful, would you wait for an overall survival benefit to now use sacituzumab in the first line, or would you use it based on the PFS benefit?
Personally, I'd be comfortable with the PFS benefit. I think one thing we'll have to keep in mind is that the Ascento-04 trial did actually provide drug for crossover in this trial. So I thought that was actually really nice. Often, when you have global trials, patients may not have access to drug in the second line setting, but here they actually said, hey, if you got chemo Pembro and you want to go on and get sacituzumab, we will give you drug and provide it for crossover purposes. So that's, nice. So I think interpreting overall survival actually may be a little bit more complicated here, right? Because everyone at least could have had the opportunity to go on to get SG subsequently. But again, it will be nice to see that. But again, if I can see an improvement in PFS in that upfront setting, I'll be very comfortable thinking about utilization.
Yeah, perfect. So let's move on to the second press release, and this is DESTINY-Breast09. And just to remind everybody, this is first line in the HER2 positive metastatic setting, where there were 3 arms. There was the T-DXd plus pertuzumab, T-DXd monotherapy, and then your Cleopatra regimen with THP. And the press release said that we have data from the T-DXd plus pertuzumab arm showing, again, a meaningful improvement and statistically significant in PFS compared to the Cleopatra regimen. So again, this is also a crowded field. And obviously we're not going to have OS benefit yet. But so how do you see incorporating T-DXd with the potential of toxicities with a 10 to 15% of ILD in that first line setting?
So I think we've had the Cleopatra regimen, the THP regimen, around for well over a decade and has been the established first line standard of care. But we've known also that T-DXd has a progression-free survival. In fact, in a second line setting in DESTINY-Breast03, that was actually much longer than what we had seen in Cleopatra. So I think we were all anticipating that DESTINY-Breast09 would be a positive trial. And so we've expected to see T-DXd move up here. And so, I think your question is a good one. I think we have to see the data to see, what kind of progression-free survival we're achieving with T-DXd in this upfront setting. But I think we're anticipating it to be even better than we saw with DB03, which would be a game changer, right, for our patients to see PFS that is, in an all-comer HER2 positive population, in essence, extending beyond 3 years would be big for our patients. So if we could achieve something in that, above that 29-month PFS that we're getting in the second line, to me, that is very practice-changing data. I think you allude to the fact that this is giving continuous T-DXd and pertuzumab as opposed to THP, where you use kind of an induction strategy and then maintenance. And so, I think there are pluses and minuses to the differences in approach. But I think if you're really, doubling your PFS or doing, something that's incredible for even what we saw with DB03, that's a game changer, and that makes it important to think about shifting T-DXd up front. So we do have to see the data to understand it better, but I think again is really exciting to be able to hopefully see our patients do even better than we've achieved with Cleopatra.
And I feel we saw the Patina trial, which was also impressive. I mean, with a great improvement in PFS just by the addition of palbociclib in that maintenance phase. And so for our ER positive patients, which are half of those HER2 positive patients that are also going to be triple positive, I feel that potentially maybe giving an induction with T-DXd and then moving on to HP plus palbociclib, right? Doing something, a combination of the two trials might be for the long run better toxicity wise, and it seems to not compromise efficacy. If at all, it really seems to have a pretty impressive efficacy, right?
Yeah, no, it's a nice idea to merge the two concepts. Obviously, I think we were very impressed with the patina data, which told us we could hit like a 40-month PFS in the first line setting. I think the challenges, though, is it was a very selected patient population, right? We took patients who got through induction therapy without progression, filtered those people out who have more resistant disease, and then showed that that population with positive disease that passes induction can do super well with maintenance with HP, endocrine therapy, palbociclib. And so that's great. I mean, I think quality of life in that setting is, usually those are very well tolerated agents. And so I think I like the idea of this merger, because I think we all think TDXD is a much better strategy than THP. And so could you think about, an induction TDXD followed by, some type of HP endocrine maintenance with CDK. And so obviously that will need to be studied more. There is a study that's ongoing called the Demether trial, which is doing sort of what you said, which is saying take the TDXD up front, give it for 6 or 8 cycles, kind of like we did with THP, and then give them HP maintenance. And you can choose to use endocrine therapy. It doesn't incorporate the CDK in that particular trial, but will give us a sense of performance of TDXD induction followed by maintenance. That was obviously not what was done in DESTINY-Breast09. Patients were treated until progression with TDXD in the DB09 trial.
And finally, of course, we're hopefully soon we'll have the data from HER2CLIMB-05, which is a maintenance to tucatinib. So assuming that data is pointing to the right direction, how do you see incorporating DB09 and HER2CLIMB-05 into your patient care?
Again, I need a crystal ball. So, I mean, I think that HER2CLIMB-05 trial is a similar idea to patina in a sense that you give THP induction, you go into HP maintenance, and you can add tucatinib. What's kind of clever about that is I think we've all wondered, could we even help prevent CNS metastases by using that tucatinib in this early setting with that maintenance strategy? And so obviously we just need to see the data, and need to look at tolerability of adding tucatinib to HP, which, can add a little GI toxicity. So I think it's hard to predict because again, what we saw with DESTINY-Breast03 was unprecedented levels of PFS in an all-comer population, not selected by hormone receptor positive status, not selected by whether you got through induction, right? It was in everyone. And so if we're achieving that with DESTINY-Breast09, that's going to set a bar that these maintenance strategies need to be able to surpass, right? And so it's hard to predict where things will go without seeing all the data. But again, I kind of like your strategy is if there was a way to think about TDXD induction in the future and think about novel maintenance strategies. Obviously, that sounds attractive, but we definitely need more work to know if that's something that could be done.
And what impressed me, obviously, the PFS was exceptional, response rate was exceptional as well in DB03. But what impressed me was the complete response of around 20%. So I wonder what kind of complete response we're going to get with that first line TDXD plus pertuzumab, right? Because many of these patients we might actually be curing with metastatic disease.
I mean, you bring up such an excellent point, which is in this upfront setting, I do wonder, there are some HER2 positive patients we've all had that, we wonder if they are cured. And if we could cure more patients in this upfront setting, that's a game changer, right? And so, well, obviously it's going to take follow up. The data from DESTINY-Breast09 we know is just going to be an interim analysis, and we will need longer follow up and be able to tease out kind of what happens to people and see what those complete responses do. But really important. So hopefully we'll learn more.
Perfect. Well, Sara, thanks so much for being with us. Thanks everybody for listening, and see you next time.
Thank you so much.